All right, so I think we have everybody. So everybody, welcome, and thank you so much for joining us today. I want to first ask everybody to mute your microphones. We're not able to mute everybody, but it seems that it's going well so far. My name is Anna McCartney-Melstead. I'm with Breakthrough Action, Johns Hopkins Center for Communication Programs. I'm based in Spain currently, and I am going to be moderating this session today, which means that I will be cutting off our presenters at 5 minutes exactly, and also moderating the question and answer session. So before we start, I want to also introduce Sharmeen Sultana, who is our Zoom expert today. And we have Gabrielle Hunter, who of course is the co-chair of the SBC working group, who's going to be providing closing remarks at the end of our session. Sharmeen, can we have the next slide, please? Super, thank you. So as before, although this session is in English, please note that we do have the slides in English, French, and Portuguese, and they are available on the link on this slide. And Sharmeen will be sharing her screen with the lightning talk slides in English. So can we go to the next slide, please, Sharmeen? So this session is about reaching the unreached. So one of PMI's key pillars in their strategic plan is about reaching the unreached. According to the President's Malaria Initiative, despite progress in scaling up malaria interventions, still more than 30% of children with fever in sub-Saharan Africa are not receiving care. These children predominantly come from the poorest and most rural families. So to reach the unreached, the currently unreached, we need to achieve and maintain coverage of effective evidence-based malaria SBC to reach remote, rural, and other marginalized communities. So each of our presentations today, and we're very lucky to have 3 very interesting and very different presentations, are going to showcase different methods on how to reach unreached populations effectively. So each of our presentations is going to have 5 minutes to present, and then we're going to have a brief 5-minute Q&A. So please type your questions in the chat as before, and I'll ask them during the Q&A sessions. Speakers, the agenda is full today, as you know, and I'm going to be timing us so we stick to this time. And if you go over your 5 minutes, we'll have to take it out of the Q&A session. So please stick to time. So with that, let's get started. So our first presentation is by Dr. Kya Min Thun from the University Research in Myanmar. So please take it away, Dr. Thun, and apologies if I butchered your name. Next slide. Dr. Thun, your turn.
Yes, thank you. Hello, everyone. I'm Cho from USC Burma. Now I'm talking about the USAID-funded President's Malaria Initiative activity, the free malaria activity, under the theme of reaching the unreached. In Myanmar, malaria transmission is the heterogeneous, and the forest girls were at high risk of malaria. According to the remoteness of work sites, they were difficult to access essential malaria services. We explore client-oriented voucher mechanism through community engagement. We applied participatory learning and action approach, which started with the community advocacy, and then we organized audience analysis and malaria mapping with the community members. By this means, we could reach out to the Goas who were the most vulnerable and marginalized. We invite them to enroll in the voucher mechanism, and we inform about the forest packs.
Sorry, Dr. Thun. Dr. Thun, one moment. Sharmeen, can you please advance the slide so we can see Dr. Thun's points? Okay, go ahead.
Yes. we applied the participatory learning and action approach as a community engagement. We started with the community advocacy, and then we organized audience analysis and the malaria mapping. By this means, we could reach to the forest goers who were the most vulnerable and marginalized. And then we invite them to enroll in the voucher and inform about forest pack, which included the long-lasting insecticide treated net, topical repellent, and the long sleeve shirts and the sack pack and the information material, designing more visual, less text, taking the characters of the forest goers and the forest setting. And we convey key malaria messages and inform them about the plan of continental care provision. And then we could organize focus group discussion and problem tree analysis to get the community solutions. By this means, we could enroll 2,000 forest goers in this study, and 69% of them were male, and 62% of them were primary school and lower level of education, and their average income was $1.5 per day. And during the course of 1 year study, 68% of them requested the additional repellent tubes, an average of 2.3 times. After 6 months of their enrollment, we follow up and met an interview with the 526 forest goers. According to the results, they revealed that 92% of them slept under bed nets, and 77% of them used topical repellents, and 63% of them accessed malaria diagnosis. Regarding the lesson learned, community solutions within the community, which should be encouraged for the dealer design, and the forest goers behavior could be promoted through utility supports and repeated messaging. The community accepted the forest packs and voucher mechanism as the incentives, and we noted that it works for the higher and greater enrollment and involvement of the forest goers. And it is also noted that by the PLA sections and the voucher mechanism, we can move easily to the change stages, to the preparation and trying to act the new behavior stage were reached after conducting of the focus group discussion and problem tree analysis sessions and provision of the forest packs. And also we integrated a 5E approach in this community engagement session to satisfy their status call. Thank you.
Thank you so much, Dr. Thun. What an interesting presentation. Anybody with questions, please type them in the comment box. We have about 4 more minutes to discuss this presentation. While folks are thinking of questions, Dr. Thun, can you tell us what kind of challenges you encountered while implementing this this very interesting incentive-based approach?
Yes, actually, it is. We can say the forest goers are the most hesitant group, and it is very difficult to change their rooted behaviors. So some kind of the incentive mechanism is needed to introduce for of the of their greater involvement. So it should include some of their utility, like the long sleeve shirts and the sack bag, which are very useful for them during their forest activity. And they are taking interested to try to use these items and along with our behavior messages and intervention items like the topical repellent and long-lasting insecticide treated nets. That approach is the first point of attracting them and to get involved in our behavior engagement scheme.
Okay, wonderful. Thank you so much. Very interesting. So we have a few people who want to know more about the vouchers themselves. How was decided what would be included in the packs, and how did they access these utilities that you talked about?
Yes, actually, for malaria prevention, the airline is the key intervention, better control intervention. But actually, most of the forest goers walk outdoor, and we need to include such kind of the preventive items for the outdoor malaria transmission. So this is the repellents and the airline are the key intervention components. And other two, like the long sleeve shirts and the sack bag, are the used for the visibility and the behavior messaging that could provide the repeated messages whenever they see it. Their awareness can be increased over time. So these are the items we included in the forest packs, and actually we want to include more items that we have to follow the compliance of the poison and the toxicity use of the USAID. So it is an innovative idea. We try to include more items for the prevention. In addition to the preventive items, we provide the key messages of assessing the importance of malaria diagnosis. Whenever they have the fever, and also whenever they return from their forest, they need to know their parasitological status, as they have been exposing in the malaria risks and the high receptive areas. So by this means, we also link with the repeated aspects by providing the information about you can get the topical repellents when it has been used, and you can take out the replacement, and this is a chance for the repeated context, and then we can provide the reinforced messaging for the behavior change process. Thank you.
Great, Dr. Thun, thank you so much. We have a couple more questions. Let's see if we can get at least one more. Janie Miller asks, do we know what the baseline behaviors were?
Actually, this study is linked with the interrupted time series analysis of the community study, and we applied the study and control of villages. And by this mean, we see the behavior impact, but also the transmission impact. We noted the effectiveness of the application of the topical repellents. By this mean, we are proposing the topical repellents should be included in our forest pack. So other we actually don't have the actual baseline because it is the new exploratory studies, and we can set the the results which might need to compare with other studies. But actually the results is pretty higher and as we expected. So we are happy to see the good results.
Great, Dr. Thun. Thank you so much. We have some more questions that we'll have Dr. Thun type answers to, and we'll send out with the notes after this. But we need to move on to the next presentation. Thank you so much, Dr. Thun. Very interesting. Sherman, next slide, please. So our next presenter. Thank you, Dr. Thun. Thank you. Our next presenter is Sochia Folk, Population Services Cambodia. So the floor is yours, Sochia. Next slide.
Thank you so much, Anas, and good evening, everyone. So I'm really have a pleasure to present you a kind of one study that we are using for the SBC campaigns or interventions initiations. It is called the malaria prevention and care-seeking behaviors among forest goers. For Cambodia, we have set the malaria eliminations by 2025, and the forest goer is considered as the front line that we need to fight in order to ensure that we meet the target of the malaria elimination. So we have put a lot of effort, not just only from PSI Cambodia, but the national program put a lot of effort in working with these target populations. We have many studies have conducted so far to understand about the behaviors and the practice in terms of the prevention and the case management amongst the forest goer. But however, we do not have any study yet in Cambodia to identify which behavioral determinants that is really influenced to the preventive behaviors and also the seeking behaviors. But in 2020s, the promoting healthy behaviors programs or projects which funded by the USAID, we have implementing, we start to conduct that study in order to identify which ones of the behavioral determinants that is really influenced to those sleeping under the net, and also the case management of the malaria forest goer. So in conducting that study, we used the respondent-driven sampling approach in 2 provinces in Cambodia. So by starting from having a 16 seed, the way that we consider this, them as to become a seed, they know a lot of a network within the areas. And each seed, we will provide 3 coupons for referral, and those coupons that comes, we will provide 3 more coupons for the referral. We continue doing from seeds to another until we don't have any referral, until we decide to stop. So as the result from that, we have collected 654 sample, and actually the target population for the study is are the forest goer that they reported have spent at least 1 night in the forest per month, and with the fever illness in the past 3 months. So from the study, in terms of the using the LLIN or LLIH in terms of the preventing, we know that the ownerships among these target population is high, which is account for 94 or 99% that they have at least 1 LLIN or LLIHN within their family. So with the high proportions of these ownership of these LLIN or LLIHN contributes to 76% of the forest goer, the reporting using always the LLIN or LLIHN. at night when they're in the forest. So as I previously mentioned, that the main objective for the study is try to figure out which determinants really influence to the preventive behavior. So from that, we can see the sorry.
May, can you please mute your line? May?
Okay, sorry.
Go ahead.
Okay, so from that, from the finding, we see that social supports and the social norms really have a significant influence to the preventive behaviors of the forest goer. If you can see the below graph, the far left and the middle ones, in terms of the social support, we see amongst the forest goer that reporting using the LLIN or LLIN when they are in the forest, 90% of them still reporting in terms of there's the support or there's an encouragement from the family or friends to encourage them to sleep under the net when they're in the forest. And the same to the social norms. You see amongst those that are using the net, or when I say the net, is referred to the LIN or LLIN in the forest. So I do not see the figure here, but the more those that have the these communities or the friends that they use the LLIN in the forest, they are more likely to use the LLIN again in the forest, comparing to those that they do not have, or they confirm that no one's, or there's less communities or the friends to use the LLIN or LLIN in the forest. So in terms of the treatments, we see that there are just only 57% of those forest goers that reporting they found treatment outsourced, while the other either not find treatments or using the home treatment instead. And among those that found treatments, we see just only 39% of them thought it or did it within 24 hours. And besides that, it's just 48 hours or more than 48 hours. Some of the cases we found they have waited until for 2 or 3 days before they decide to find the treatment outside. And again, for these treatment-seeking behaviors, we see the social norms really one determinants that is a significant influence to these care-seeking behaviors. For those caregiver or for those forest goer that they say their majority or the people within the communities seek treatment within 24 hours, they are more likely to do so when they have got the fibrils, comparing to those that not mentioned about the practice of the communities or the friend in terms of early to find the treatments when they got any symptoms. So as the lesson learned from this study, we can see the insufficiency or the availability of the LLIN or LLIN, it really contributes to the LLIN usage in terms of and the social norms and social supports are the key determinants for improving the behavior in terms of the against sleeping under the LLIN or LLIN when in the forest, and also seeking the treatment within 24 hours. So from that standpoint, the SPC intervention should focus on these two determinants in order to come up with the intervention and campaign, and comes up with as the activities to roll out for with the communities. Yeah, I think that's all from me, and thanks.
Oh, thank you so much, Sochia. That was really interesting. And I think that it was a really great compliment to the previous presentation. So we do have some questions. We'll start with this one about what is the level of access to nets in this population? And is there a rate of net use among all respondents or among only those with access to ITNs only?
For this study, we just only focus on the forest goer, and we see the proportions of the forest goer that they're reporting of having at least one LLIN or one LLIN within the family for using. We see 94% of the forest goer reporting they have the LIN, and 99% of them reporting they have the LLIN for them to go to the forest. We have the mass campaign in terms of the net distributions across, across all the country. And there's another source of the study, the Cambodia Malaria Survey study, focused not only on the forest goer, but it focused on the households as well. But the proportion of those households still, in terms of the net access, it is around 90%, something like that. But the rate of using the LIN or LLI agent, it is really lower comparing to the forest goer. Hope that I can answer to your questions.
Yeah, that's great. Thank you so much. We have a question from Nurul. May I know regarding the influence of social norm and preventative behavior, how could we tackle this context? So I think he is asking, how do we, with this knowledge that social norms are such a big influencer of behavior, what do we do with that information?
With that information in terms of the campaign designs, actually, there's another stage that after we having this result, we have identified which determinant or behavioral determinant that we need to focus on, and what is approach that we need to do in order to encouraging or putting the communities together in order to help in fighting, to come up with the tools, to come up with the interventions activity. So another teams have got those determinant ideas, and they go to the communities and they brainstorm about how well do people communicate to each others. They brainstorm about how can we move on in terms of designing of the FEC campaign, and who can be the engagements to identify who is the influencers within the communities. So we decided to use the two channels. One is the village malaria workers, which is the community-based worker, and also the family households to as the influencer to the forest goer. So any tools that we produce, any equipments or message that we design for encouraging the forest goer to have the early testing needs to deliver through those guys. So the BMW brings the tools to meet with the households to households, and also talk to the family members in order to continue informing to the forest goer. And whenever we move this in the, throughout the country, throughout the village where we target, it becomes the kind of the mechanism in terms of keep informing to each other, keep alerting to the forest goer in terms of what is the kind of the preventive activity that they should consider when they're in the forest.
Mm-hmm. Very interesting. Thank you. That's a great explanation. We have a couple more questions. One is from Kin Mon Mon. I'd like to ask whether the forest goers use LLIHN and LLINs, and do they use repellent? So I'm not sure if your study examined repellent use or not.
Yes, we did include as well for the repellents to try to see what is the proportion of the repellent that has been used, and what is the perceptions, what is the intensiveness, intentions in terms of using that. We see that the rate of the using the repellent is really low. It is around 10% or less than that. I'm not remember quite well, but I can tell you it is really low in terms of the repellents. One, it is about the availabilities and the affordabilities. Even there's the small interventions of introducing the forest package by adding the repellents in that into the forest package, but the implementing area is not big, so really low proportion of the forest goer that they can access to the repellents, and at the same time there's the misperceptions in terms of using the repellents. They consider in terms of it might affect to the skins. They will bring a rash, and not really believe that it is really powerful enough in terms of to prevent them from the mosquito. So there's still a big gap in terms of the repellents and the forest goer. That's why we see right now the proportion is really low.
Really interesting. Thank you so much, Sochia. We're going to move on to the next presenter, and any other questions not answered will be answered via written response. So our next presenter is Sean Wilson. He's with Johns Hopkins Center for Communication Programs, Breakthrough Action in Guyana. Sean Wilson, it is your turn. You have 5 minutes. Thanks so much. Next slide, please.
So thank you very much, Anna, and hello, everybody. I'm happy to be able to present on the project in Guyana. So malaria rates are highest among men in hard-to-reach gold mining populations or areas in Guyana. The Ministry of Health introduced a community case management model to increase access to malaria services. However, with the introduction of that model, barriers to testing, treatment, and adherence remained. And the ministry and Breakthrough Action therefore designed a multi-channeled social and behavior change campaign. We call it Little Mosquito Big Problem campaign, based on formative research to address the barriers. We spoke with several persons, including miners, camp managers, and the owners of those camps in some instances, healthcare workers, and regional officials from in those areas where the camps are, or communities or regions where the camps are located. And based on the results of the findings, we held a design and test workshop to develop our prototypes, test them, adjust them, finalize, and then we scale up. The pictures that you're seeing just to the bottom of the picture represent some of the channels that we've utilized in the campaign. These include social media. We've used posters. We've got the signage from the campaign. We've got a malaria toolkit towards the bottom left. And we've got also the rapid counseling cards that are used also for training. Monitoring of our interventions is done using a continuous monitoring form, supervisory visits, and a recently fielded end-line survey. In terms of the results, the monitoring data showed that 45% of miners reported seeking care within 24 hours of symptoms. 73% of miners reported completing treatment during a recent episode of malaria. And the recently fielded end-line survey in the graph below to the right revealed that 77% and 20% of miners recalled exposure to our campaign messages and awareness of local volunteer malaria testers, respectively. As exposure to the malaria SBC campaign activities increased, so did prompt care seeking for fever. And this is considered to be statistically significant. In terms of the lessons learned, we recognize that the SBC content that miners identified as important in our formative research and delivered through channels at times that cater to their media habits resonated with miners. Monitoring allowed rapid identification of successes and challenges and quick adjustments to the campaign. For example, we recognize that radio was not reaching some of our miners in some places, some communities. And so we decided instead to utilize direct television, where miners had a greater access to, in the evenings, they would go to bars or at the landings to look at the news or at sporting events. And therefore they had an opportunity to see a lot of our messages that were aired during those news segments or sporting activities. Malaria message recall and testing and treatment behaviors showed improvements over our baseline. And the baseline survey revealed low prompt care seeking, which is 36%, and the malaria testing 48% among miners with fever. So I think maybe just to add because I think probably may just have a couple of, maybe another minute or two left. In terms of the continuous monitoring form, we basically ask 4 questions, and these questions are asked by the volunteer testers, and they focus on prompt care seeking, persons who self-medicate, treatment adherence, and a secondary objective relates to sleeping under a treated net. So for instance, in the first question, we would ask, the tester would ask the minor, how many days, did you feel sick, or how many days ago were you feeling sick? And since you became sick, what medicine did you take before coming to get the test? Because in our formative data, there was a lot of self-medication. Then the other question in terms of treatment adherence focused on the last time, for instance, that you tested positive for malaria. Did you complete the treatment given by the Ministry of Health? And for that question in terms of LLIN, we would ask, did you sleep under an LLIN last night? So I'll stop there and be able to respond to any questions.
Yeah, very interesting, Sean. Thank you so much. We have a number of questions, of course, and I think it's a tribute to your presentation. So there was a few questions about channels. So you mentioned posters. What would you say were your main channels that you used for your campaign? Sean?
Sorry, I didn't realize I was muted. Yes, if perhaps Charmaine could bring it back to the slide itself, that would be great. But while she's doing that, okay, great. So we use social media, and we also used posters. We realized that posters were quite effective, and some of these were mounted at different places in the areas where miners are. And then to the bottom left, you see there's actually a photograph with 4 persons there, including one of myself. That is the signage. So that, for example, what we realized when we did a formative research was that miners did not know, for instance, that a volunteer tester was, close by. And so we realized that in order to correct that, it was necessary to put the signage in front of the location, whether it was at a shop or at an actual mining site, so that miners would know that they could get free testing. We also have developed a toolkit that the testers can include their medications and other reporting forms. And then we also have what we call a malaria treatment adherence envelope. And in that treatment envelope that was recently launched, the treatment for malaria is included in that envelope, and it shows on the envelope how the parasites are reduced from the body. And we found that when we piloted it, it was really helpful, encouraging miners to really adhere to their treatment. Also, they recognized that malaria could actually be cured, and they saw that as they took their medication, that the parasites were reduced, because many of them did not realize that malaria could be cured. As I said, also, we use television, a lot of ads in the television, during times when miners would frequent many of the bars or areas where they may listen to sports or look at sports or news. So we would have our ads interspersed during those times, and those have worked effectively. And like I said, radio has also been used, but in some instances we've had to modify that because in some areas it is difficult to access radio. So we've used a combination of channels to reach our target audience.
Mm-hmm. No, that's interesting, and exactly what you're supposed to do. That's fantastic. And it's interesting because it seems like this is one of the kind of rare situations where knowledge was actually really lacking. In many contexts, knowledge is not one of the determinants, but rather other psychosocial factors. So this is interesting that knowledge was such a big contributor here. So Janie Miller asks, is there much ITN use in this population?
Yes, there is. ITN use is not one of our main objectives to target. However, we also recognize that it was important to target this because it is the primary preventive tool that is used by the National Malaria Program. In fact, since the project started, we've had 2 mass ITN distribution campaigns that we've also supported with SBC materials. And the last one's actually held last year. And because of the, as it says, hard to reach populations, the ministry is still really trying to ensure that all of those areas that can become infected with malaria, ensure that they receive the ITNs. There's some people have said, listen, I would like to use an ITN, but it's difficult to access it. That is one of the aims of the ministry, to really continue to push for the use of ITNs, and they continue to try their best to ensure access to ITNs as much as possible.